This is Chapter 19, Assessing Thorax and Lungs. The Chapter 19 objectives are describing the structure and function of the thorax and lungs, identifying the landmarks and the underlying structures of the thorax, the vertical landmarks, and the horizontal landmarks, discussing risk factors for lung cancers and the ways to reduce the risk, describe all the teaching to reduce risk and promote thorax and lung health, observing an accurate nursing history of thorax and lungs, and discussing an assessment using inspection, auscultation, and palpation. We will ask you to differentiate between normal or expected and abnormal findings of the thorax and lungs, and describing assessment findings with the older adult. Then you will analyze the data with the interview and physical assessment of the thorax and lungs to formulate nursing diagnosis. So to begin with, the anterior landmarks, the clavicles, are horizontal landmarks. The vertical landmarks include the sternum, suprasternal notch, the manubrium body of the sternum, the xiphoid, and the sternal angle. The costal angle is the angle of the ribs. You have 12 pairs of ribs and all the corresponding costal spaces or rib spaces. The posterior landmarks include horizontally the scapula and vertically is vertebra prominence C7 and the whole spine. Some of the vertical reference lines are in the anterior chest is the mid-sternum and the right and left mid-clavicular lines, which is the space from the suprasternal notch to the end of the clavicle. In the posterior thorax, you have the vertebral line or the spine, and then the right and left scapular lines, which is mid-scapula on both of those. In the lateral thorax, you have mid-axillary line and the anterior and posterior axillary lines. So here's a picture of some of these structures, and you'll want to know the terminology for all these structures. This should be a refresher because you had anatomy and physiology. But now we are going to palpate these things. It's so important to be able to visualize these structures because all your patient's thorax is going to look different from the outside. But your most similar landmarks for the human body are what is going to help you to identify where structures are located underneath the skin, right? You can see this red line here, that is the diaphragm. And so where the diaphragm sits is the base of the lungs. So you know the lungs sit right on top of that diaphragm. That is the way those structures are built. So keep that visualized in your mind. If you're listening to lungs down in the intercostal spaces of the ribs of 8, 9, and 10, there's no lungs down there. So it's more difficult to hear. So knowing your landmarks, where things are located, are going to help you be able to auscultate more efficiently. So be very familiar with these structures. So the structure and function of the lungs. So you have the mediastinum, which is the trachea, bronchi, all those spaces in the central part of the lungs. The trachea we know is anterior or in front of the esophagus and bifurcates into the right and left main bronchi. You know the trachea branches into the bronchi, which branches into the bronchioles. So thinking about those structures is important to understand how things work and what is happening here. So the air travels through the trachea into the main bronchi, to the bronchioles, and to the alveoli, where gas exchange occurs in the capillaries around the alveoli. Those alveolar sacs are directly involved with gas exchange. So the structure and function of the lungs. So this includes the anterior apex is the top of the lung space above the third clavicle, and the base is down at the level of the diaphragm or the sixth rib. You can kind of see the sixth rib is at the same level of that xiphoid process. Laterally, it extends from the apex of the axilla down to the eighth rib, and posteriorly, the C7 marks the apex, and the T10 goes all the way down to the base. You can see by this picture that the size of the lobes, and that there's only 2 lobes on that left side because of the heart. The pleura surrounds the lung space. There's 2 layers of serous membranes. The parietal pleura is against the chest cavity, and the visceral pleura is against the external lung surface. There's lubricating fluid that allows the lungs to expand and inhale and exhale with a friction-free movement. So we also know that our air moving in and out of our lungs are critical to supply oxygen for energy. They expel CO2, the carbon dioxide, and they provide an acid-base balance for the pH in the body, along with the kidneys, etc. So the vertical expansion through the contraction of the diaphragm is an important piece. And so we have AP diameter, which is anterior to posterior diameter, and your transverse diameter is the long ways. So it's starting to talk about some of the diagnosis that we see with our thorax and lung disease. So chronic obstructive pulmonary disease, or COPD, you're going to hear frequently. This is a group of lung diseases that can block the airflow and make it difficult to breathe. So this is an inflammatory response. The airflow, airway constricts. And so with the airway constriction, a lot of times mucus will collect very easily and be difficult to expectorate. So exhaling is difficult with this inflammation. So a couple of these diagnoses include emphysema and chronic bronchitis. So some of the risk factors, you may not be surprised that cigarette smoking or inhaling chemicals is a big risk factor for this diagnosis. And this could be whether it's in part of the occupation or if it's a recreational thing. We see this even in vaping and lots of different ways people inhale any type of chemicals into their lungs. Some of the education you'd provide is to avoid doing this. If your lungs are responding in an inflammatory way, that means your body is not dealing well with those chemicals, and so we'd want to avoid that. If it's with a job, we use respirators or something like that to help protect the lungs from inhaling chemicals. Another diagnosis that Weber and Kelly talk about is lung cancer. And again, lung cancer, or any type of cancer, is an abnormal growth of cells. And we know that when cells are damaged, they are at risk of growing abnormally. So this occurs with smoking, whether it be direct or indirect with secondhand smoke, exposure to chemicals, radiation, and even family history can put somebody at risk for lung cancer. So obviously avoiding putting chemicals into the lungs is the priority, and seeking assessment. We know that if somebody has issues, the earlier we can address them, the more likely the patient can recover. But you know, we see this with the firefighters that were in 9/11 and addressing all that asbestos and things from the buildings, and they all had pretty severe cases of COPD and lung cancer, really dramatic respiratory situations. So protecting your lungs is so important. So when we talk to our patients about any issues with the thorax and lungs, we're going to ask them about their dyspnea. Well, the patients know what dyspnea is? Maybe not. So we talk about shortness of breath. And it's always important if your patient has shortness of breath, what were they doing? Are they short of breath at rest? Or are they short of breath with exertion? This is important to note, because if I run up 5 flights of stairs and I'm short of breath, you might expect that. But if I'm laying in bed, I'm doing absolutely nothing, and I'm short of breath, that is important to note. Now, do I need pillows at night um, to help me to sleep? Because it's hard for me to have a full chest expansion when I'm laying flat. That is important to note. And also any associated factors that I might have with my shortness of breath, like edema, chest pain, sleep apnea. That's really important to note. Any chest pain. Sometimes people have respiratory issues and they have of chest pain from that. Maybe it's not necessarily cardiac, maybe it's more muscular from coughing so much or doing the deep breathing. There also is something called pleuritis, where that's an inflammation of that pleura that surrounds the lungs, and it can be very, very painful. We know that respiratory versus cardiac origin can be difficult to assess, but I would say that if your patient is having some chest pain and you elevate the patient, raise their head of bed, and that chest pain is resolved, a lot of times you might see that as respiratory. Because if you think about it, if somebody's having chest pain in a cardiac way, there's an occlusion in a vessel around the heart. And changing their head of bed or position is not going to impact that ischemia around the heart, right? Now, if somebody's having GI symptoms, a lot of times GI symptoms or things like that can be connected with some respiratory issues because of the coughing and all that stuff, and the wheezing, asthma. So knowing when the patient's having the heartburn, the onset, and connecting that to any respiratory issues might be something you may not expect to ask your patient about, but it can be important. If your patient's coughing, what time of day are they coughing? Are they producing sputum, or is it non-productive cough? Is it a dry cough? Different colors of sputum might indicate different things. If somebody is having just clear white sputum, or those type of things versus a yellow, green, brown sputum. A lot of times we connect that yellow, green, and brown with a uh, bacteria growth. Bloody sputum, those type of things, we see patients coughing up blood and things like that with cancer. And if somebody has a severe cough and they're coughing so hard they break some capillaries, they might have that experience. That rust colored, a lot of times that sputum we connect with tuberculosis. And that pink and frothy is something that we see with pulmonary edema. And interestingly, there was a situation with some athletes who were swimming in the ocean and were spitting up pink frothy sputum, and people didn't know what was happening, but they were getting some pulmonary edema from being in the super cold water. Wheezing with coughing, definitely when wheezing occurs, and we'll talk about that shortly, that's air moving through a tight passageway. And so we know that bronchitis, things like that, we connect with that wheezing with a cough. Lastly, we're going to talk about any history for patients. We talked about lung cancer, asthma, that inflammatory situation, any history of COPD with the family, or smoking even in the household. Lifestyle and health practices, nutrition status, smoking, of course. And we're always going to ask our patients, what have you been doing to help? There's so many over-the-counter things that people take, Claritins and cold medications and Flonase and all these kind of things. So even if they're over the counter, it's important to talk to your patients. There's also things, sinus flushes, and I'm sure there's other herbal type things that patients utilize when they're trying to uh, help and assist their breathing. So it's important to kind of know, what have you been doing to help with this at home, or have you been doing anything, etc. So when we're assessing your patient, we are going to expose the chest, but you're going to drape one part at a time, especially for women in the anterior portion. We're only going to expose the part that we are going to listen to. So this is where your landmarks really come into play, because you need to know, where am I going? What am I trying to listen to? You're going to explain to the patient, when I put my stethoscope on your chest, you're going to take a deep breath in and out. You want your patients to be relaxed with the arms at the sides, and always clean your stethoscope, your bell, and your diaphragm before you listen to your patient. But you're going to assess and auscultate with the diaphragm for lung sounds. So first we're going to do the inspection. So this is something that probably, as you're meeting your patient, you're already assessing for any signs of distress, like nasal flaring, pursed lip breathing. All of those things are signs of distress. We're observing for color in the face. We know that with patients having a bluish tint to the lips or face, we know that is central cyanosis. We're going to inspect the nails and note for any clubbing, making sure the tips of the nails are pink, and the cap refill, etc. When the nails are curved around the tips of the fingers, we call that clubbing. We're going to look at the chest and the shape of the chest. We are assessing for AP and transverse diameter. Does your patient have a barrel chest? Is the sternal position midline? We're observing your patients initially. Are the respiration rate, is it even and unlabored? 10 to 20 per minute is an expected finding for your patient. Is your patient requiring accessory muscles? We should not have to use our shoulders or hands to hold your shoulders up. You should not be able to see any sternal retractions, but we're inspecting if you can see intercostal spaces for those things. In the posterior chest, you're again looking to see if we have symmetry to the scapula. We know that if any scapula is protruding, sometimes we see that with a scoliosis or lateral deviation. Again, the spine should be midline, and the thoracic cage should appear symmetric. So here are some pictures of that abnormal inspection, that lateral deviation of scoliosis, and the AP to diameter, or the barrel chest. So if somebody is using accessory muscles, that may be related to that tripod position and COPD, somebody putting their hands on their knees to try to bring their shoulders up to help their breathing. So when we look at somebody's position, we want them to be upright, relaxed, and breathing even and unlabored. Now, if somebody has fractures on a rib, they may guard on that side and not breathe symmetrically. So it's not just COPD, there may be other things, or if somebody has pleuritis on one side of the lungs or things like that, they may be asymmetric, but you would want to document that. So when we're palpating, We're palpating for tenderness, sensation. You're always going to ask your patient if they have any tenderness anywhere. The expectation is obviously that they wouldn't, but if there's any fractures, osteoporosis, any pain with coughing or muscular muscular pain from coughing on one side versus the other, that could be a concern. We're also going to palpate for crepitus, which is kind of a crackling that air is leaking out of that pleural sac into the tissue. And this only typically happens if there is trauma, because we know those pleural sacs are encased and they are pressurized there. So maybe if there is a fracture or a puncture, or maybe there's been a chest tube or something like that, that can cause trauma to that area. So you are typically not going to do look at chest expansion in this way, but this is uh, something you might see other people do. So this is just for information only, but you should know that unequal expansion of the lungs can happen with atelectasis. So atelectasis is that collapsed part of the lung, or pneumonia where there's fluid in that part of the lung, like pneumothorax. Those type of things are injure the lung on that space and cause unequal chest expansion, which we know if the chest is not expanding in that lung space, the patient's not getting the benefit of the oxygen in that lung space. So when we auscultate the anterior chest, we go below the clavicles. We are going to do side to side because you want to compare upper thorax to upper thorax, lower thorax to lower thorax. We are not going to listen over the breast tissue. We want against the chest wall as much as possible. And you're going to listen to inspiration and expiration. When we're listening to the posterior chest, we're going to have the patient lean forward slightly. And when you get to the base of the lungs down at the T10 space, the thoracic intercostal space, T10, you may have to have them take a deep breath a little bit more. But we're going to start below the C7 of the vertebra prominens at the apex and go all the way down to the T10 at the base. So here's an example of where and what we're listening for. I think it's important to note the location and what lung sounds you are trying to assess. So in Weber and Kelly, they have 20 different places to listen to posterior, but you are not going to have to do that. You're going to have 4 places, anterior, 2 upper thorax, 2 lower thorax, and 2 each lateral, and then you have 6 posterior. So your 6 posterior are located in the 1 and 2 position, the 8 and 7 position, and the 17 and 18 position. In the front, your 4 places are in the 3 and 4 position and in the 9 and 10 position. So your expected breath sounds are bronchial or tracheal. Those are the loud, high-pitched. You think of the trachea as a larger tube. Those are bronchial tracheal sounds. The bronchovesicular are against the sternum and against the spine in the back at the first and second ICS. They have a moderate pitch. The vesicular is where you are going to listen mostly, and it's lower pitched and it's heard over the peripheral fields of the lung. So here's a picture of that. You see the vesicular is almost all the lung sounds that you are going to be listening to for your checkoffs. Now, your abnormal breath sounds. So abnormal breath sounds, diminished or absent, means that there's little or no air moving in and out. There's an obstruction somewhere. And we see this sometimes with that hyperinflation due to emphysema. That is the obstruction. Now, the increased or louder sounds are the consolidation or the compression in that dense lung area. And uh, later, pneumonia can cause consolidation with that fluid. Now, adventitious sounds are wheezes and crackles. So we're going to talk about those added sounds that are superimposed over normal breath sounds. And they don't have to be in all areas and all lungs. They could be just in a couple places. So wheezes are musical sounds. Not the music maybe you want to listen to, but there's high-pitched wheezes, inspiratory and expiratory, and then there's low-pitched wheezes. But I just want you to know what wheezes are. That's air passing through constriction, whether it be swelling or secretions. Um, Diagnosis like asthma or emphysema can cause these types of things, in addition to bronchitis. Now, there are crackles, fine crackles, coarse crackles, and atelectic crackles. So, crackles are air moving through fluid, and the inhaled air tries to open those deflated passageways that are kind of sticky with phlegm and exudate in there, and it causes that bubbly sound as air moves through fluid. We see this with congestive heart failure, pulmonary edema causes crackles, asthma, if there's fluid in there, bronchitis. So it's bubbly, moist sounds. And I know this sounds really terrible, but that crackles, remember, is air moving through fluid. Now, the um, the atelectic crackles. So, if somebody is sleeping all night and they have not cleared their lungs first thing, and you go in there at 7 a.m., you're going to have them take a deep breath and cough from down in the diaphragm to clear any mucus or anything that's collected overnight. And then you're going to listen to their lung sounds. Now, because the alveoli may not be fully aerated because they've been sleeping. And a lot of times when people are sleeping, they're not taking the deep breaths that they are during the day, especially if they're bed rest. So if the crackles clear with the cough or disappear after those few breaths, those are atelectic crackles. Okay. What the sounds that you hear after somebody clears that is what you're going to document. Now, stridor and pleural friction rub are things that you won't commonly hear, but when you think of stridor, you're thinking of obstruction. It is air, high-pitched, um, uh, bronchospasms, obstruction. This is an emergency because obviously ABCs, airway, is the priority in making sure somebody has an appropriate airway. Now the pleural friction rub, we talked about the pleura around the lungs, the two pleura, and when there's inflammation of those pleura, or there is a lack of that serous fluid that's in between the pleura, the pleura rub against each other and cause a friction rub, and it is coarse and it is grating. It sounds very, very, very painful, but we see this sometimes with pleuritis. So the respiratory patterns, we know the expected finding is 12 to 20. Tachypnea is greater than 24, and bradypnea is less than 10. So your patients with hyper or hypoventilation, when they have tachypnea, but the hyper or hypoventilation is the lungs are not able to do appropriate gas exchange. Um, so we'll talk about that further. The Cheyne-Stokes respirations, we see that at end of life. They're irregular and typically maybe less than 10, but more irregular. So we assess for cyanosis in pale skin, um, and we see that as blue tinged, and we look around the mouth and the nail beds for peripheral cyanosis, etc. In darker skin, cyanosis may appear more blue or dull and lifeless in the tissue. So some of the respiratory conditions that we're going to talk about include pneumonia, bronchitis, tuberculosis, emphysema, and asthma. You'll want to know what the pathology for each one of these respiratory conditions are and some of the priority diagnosis assessment findings that you'll see in these patients. So you can differentiate if your patient is having some of these assessment findings. So for example, we know pneumonia is a bacteria or infection where the alveoli become consolidated with bacteria or fluid. And so we hear this with increased breath sounds, crackles, and increased respiratory rate as the patient's trying to compensate. So be sure you're looking at these respiratory conditions and being able to differentiate with different patients. In addition to that, we're going to talk about atelectasis, heart failure, pneumothorax, and pulmonary embolism, along with pleural effusion. So be sure that you're able to differentiate these diagnoses and the findings that are connected with these specific patients. Weber and Kelly talk specifically about asthma because this is so common, especially here in Texas. We see a lot of allergies and asthma, and we know that as a inflammation of the bronchioles and bronchi, along with bronchospasms. And some of that edema of the bronchioles and the secretion of the mucous airways can cause dyspnea and chest tightness and those audible wheezes, because we know inspiratory and expiratory wheezes are connected with inflammation of the airway, air trying to move through a tight passageway. Pneumonia, again, is the diagnosis that Weber and Kelly focuses on, which is, again, infection in the alveolar membrane, causes inflammation and collection of mucus. And so patients quite often experience cough with sputum, shortness of breath. They can also experience fever as the body's trying to fight the bacteria. So we see your patients have increased respiratory rate and decreased chest expansion, especially on the side where the pneumonia is collecting there, and crackles as air is trying to move through the fluid that's in the lungs. If it's consolidated, they may have that increased or louder breath sounds. So some of the nursing diagnoses that we'll see in this chapter, the priority always is airway, right? The gas exchange, the airway clearance, and the breathing pattern. But we'll also see activity intolerance because your patients get short of breath with exertion. But always the ABCs are the priority, right? So in summary, you want to be familiar with the vertical and lateral landmarks. Your respiration and ventilation, what does this mean? What are the mechanics? And the pleural membranes, which we talked about multiple times. What are some of the older adult considerations that we have to look at? And what are some of the risk factors for those big diagnoses, COPD and lung cancer? How are we assessing the respiratory system? Inspection, palpation, and auscultation. And what are your abnormal findings and expected findings? If you were seeing a patient in respiratory distress, how would you know? How would you be able to recognize that? Can you describe the related diagnosis to the breath sounds, whether it be absent or diminished, the crackles and wheezes, all of those type of things? Do you know the terminology for bronchial, bronchovesicular, vesicular, hypoventilation, hyperventilation, Kussmaul, and Cheyne-Stokes? Those are terminology you might want to be familiar with. And then lastly, how would you identify the correct nursing diagnosis of impaired gas exchange, ineffective breathing pattern, and ineffective airway clearance? Thank you.